Remember, there are a lot of medications, 20 FDA-approved medications. Most of them are very effective in about 50% of patients. You may have to try a couple things. And actually, we say that lightly. We may have to try a couple things until something's effective is found. But that can be very frustrating for people because that could be a couple months. That could be like 6 months until you find something that works. And I think the job of a lot of people, especially the care managers, is to be a coach, right? To be kind of like a cheerleader from the side, this is really frustrating, but really going to find something that works. If you have access to CBT, I think that's great. You should really try to use it. And if you get involved get more actively involved in this study, figuring out how to adapt education and cognitive behavioral therapy approaches to your particular setting is going to be really important. But even with the therapist, let's say they go from a 20 to like a 12, and the medications aren't working. If they go on the third one, it might get them down to a 4. Let's see. If medications are not effective at a therapeutic dose, make sure they're taking it. Mike says consult with a prescribing prescriber, meaning make sure that the prescribing provider even knows that because there's not a lot of communication even in primary care clinics, as we all know. If you have access to a psychiatrist, on the more difficult cases where people don't get better, you might want to save all your cases for those people so you conserve resources. Give, quote unquote, the simpler cases to the primary care provider. Let's see. And if people don't respond, you want to do all the things that we talked about. Change the treatment plan. Most people need changes. I mean, it's treatment adjustments. As we said before, only less than half will have a complete response on the first time around. What is a plan B? So we've gone through this very quickly. For partial responses, augment with another medication or psychotherapy. Switch to psychotherapy or another medication. I generally do both. Combination therapy, also considered combination therapy. Augmentation will also I'm actually specialty mental health, but sometimes I do get referrals from primary care, so pediatricians or internists or family practitioners, where they sort of consult with me. So if you have access to any mental health resources, I think within this study we're going to try to figure out how to make that happen. But you may want to ask about like St. John's, for example. I love your clinic, and I'm very familiar with it. But maybe there's some way to provide a resource like 2 or 3 hours a week where you could hire a psychiatrist where they could work on those sorts of things. ECT. ECT is not an evil thing. It works really, really well, especially for people who don't respond to any antidepressants whatsoever. But this talk is not about ECT, but it's very safe, it's incredibly effective, and the big side effect with it is memory loss. But people do incredibly well with ECT.
Is it readily available?
Yes, it is readily available. Yeah, except for adults, it is. For kids if you're a kid, you can't get it. I mean, you need like a court order. Even then, I'm not sure you can get it. So. Let's see, one more. I'll do one more and then go. You can go. See consultation with a psychiatrist if they're really, really bad. I mean, they're just not moving. The type, they don't bathe, right? They're, like for days, they're just sitting in their room, right? They look like they can't move. They're practically catatonic. They whisper when you talk to them, right? They failed to respond to treatment at all, first, second, or third treatment. If they have a personality disorder, and you know what? I would be careful about personality disorders. People who are depressed and anxious are irritable. They can be ornery. They can split, right? Mm-hmm. And when they're better, they're fine. So be very careful about personality disorders. Substance use, though, is a big deal. So if they're using speed or opiates or lots and lots of alcohol, you may want to get some consultation on how to manage that. Bipolar or psychotic, that's obvious. Is suicidal or homicidal? I think that's obvious. You want to go.
All right, so this is where we talked about risk, when to stop antidepressants, something that we've already sort of talked about. And I think that the main thing is that we really want to reduce the likelihood of people relapsing, because we know that the likelihood of somebody having depression again, if they have a major depressive episode, is pretty high. Right, so we know that the risk is 50% if they've had an episode of depression in the past. So half of those people who've had depression in the past are going to have depression again. It's even higher as they've had multiple episodes, as you can see here. By the time that they've had 3 episodes, it's pretty likely they're going to have a 4th one. And we also know that the risk of having depression is also higher if they also, have dysthymia. Again, if they have sort of that low-level chronic depression-like syndrome, or if they have residual depressive symptoms. And again, this is where we get back to that issue of, recovery is the rule, but, so you could get better and you might not take the medications, which is part of the reason why with some of these studies it suggests that they might be effective, might not be, because people do get better, but they often will have these residual depressive symptoms and they won't really get all the way better, and then they'll more likely have an episode down the road. So so we definitely want to make sure that we prevent that from happening, but we also don't want patients to be on medications all the time. Nobody wants to take a pill for the rest of their life if they don't have to. So again, we generally want to, first of all, get that initial response. We want to make sure that patients get better first. Once they're better, then we can keep people on the sort of maintenance dose, make sure that they're on a good, that they're doing fine for a good set period of time. So, as I mentioned, I generally tend to do sort of 6 to 9 months. A year is fine as well. And probably for the populations that we'll be working with here, they probably do need to be on longer than just sort of, 4 to 6 months or something like that. They probably do need to be on a bit longer because many of them are going to fall into these other categories where they've had prior episodes of depression in the past, unless we're working with younger people who haven't had an opportunity yet to have depression. So we also want to treat those who are at high risk for relapse for 2 years or even longer, as we mentioned, potentially indefinitely, for some of these people who have frequent episodes of depression. And as we mentioned earlier, some people may need lifetime treatment. But the main thing is that we want patients to be better. That's the ultimate goal. And of course, people always say, "Well, I don't want to take a pill." But on the other hand, when we see what they're like when they're better and when they're worse, I think that it's often not that hard to work with patients in terms of explaining to them what those differences have been and why it's really important for them to stay on treatment if they need it. Maintenance treatment should be at full dose. You don't want to, just because they're doing better, you don't want to start cutting things back because you're likely to push them back into depression again. And I think that the main thing is you want to work with them in terms of a relapse prevention plan. So we know there are certain things that might make things worse. So we want to try to avoid those triggers. So as we talked about the cycle of depression, if we know that there are certain things that tend to make people worse, or for example, people who are have substance use disorders, if we know that drinking is a problem for them, we want to try to minimize that and work with them on that and stop the disorder. And then finally, we do want to taper slowly because, again, people do, experience some of these problems in terms of coming off of the antidepressants. And, I think that the main thing is, if they're experiencing some problems as we're trying to discontinue the medication, just go slower.